Hello, everybody. Welcome to today's webinar, What You Don't Know About Virtual Second Opinions is Costing You. I'd like to welcome you all today and thank you for joining us. My name is Goche Sezgin, and I am the head of marketing at the Clinic by Cleveland Clinic. Before we get started, I'd like to cover a few housekeeping items with you all. First, we would love for you to ask questions as we present today, please. So please use the question option on the toolbar to enter any questions you have, and we'll plan to answer as many as we can at the end of our presentation. To be able to submit a question, just click on the little arrow next to the word questions on the toolbar and type your questions in. This is also where you can send any technical questions. From our presentations from before, one common technical question we get is about the sound. Sometimes people can't hear the presenters well. If that happens, click on the arrow next to the audio option this time and choose phone call instead. That will give you dial instructions so you can still enjoy the presentation today and be able to hear us well. People also ask about getting the slides. The slides are available for download. We will also send them to you after our presentation as well. Now I'd like to introduce to you all our presenters. We have two presenters today, Frank McGillen, our Chief Executive Officer at the Clinic by Cleveland Clinic, and Dr. Peter Rasmussen, Chief Clinical Officer at the Clinic by Cleveland Clinic. They will be sharing some very helpful information about virtual second opinions and how it can help improve outcomes and reduce costs. Before I hand over the reins to our presenters, we wanted to take a quick poll. So let me make this poll visible to you. We'd love to know how many of you are familiar with the concept of virtual second opinions. As we get started, I'm going to give you guys about 30 seconds to respond. We're asking this so that Frank and Peter can further elaborate on some points in the deck if needed. So go ahead and respond, please. I'll give you guys just a couple more seconds. All right, awesome, thank you. So I'm going to close the poll right now. It looks like about 80% of you are at least somewhat familiar with the concept. That's great. We'd like to talk further and discuss more on this topic and learn more together. All right. So thank you very much. That was very helpful. And now I'm going to hand things over to Peter to get us started, and then Frank will continue after, and I'll be back to facilitate our Q&A at the end. So go ahead, Peter, take it away, please.
Great, thank you so much, Kochi. You know, when I was a young man in my early 20s, I used to take my grandmother to her physician's appointments. And after she would get back in the car after seeing her physician, she would routinely say to me, you know, Peter, Dr. Smith is the best doctor. And, you know, we all want to believe that we're seeing the best doctor. And in my own clinical practice, I hear this almost every day, where a patient will tell me, you know, Dr. Jones sent me to you. He told me you were the best. It's only natural to really want to believe that we're getting the best health care. Unfortunately, what we're finding more and more is that the doctor is not always getting it right. And what we're finding is that about 5% of the time, there is an error in diagnosis in the outpatient center. And if you think about having a very complex disease like cancer or neurologic disease or cardiac disease, that's really a fairly unsettling statistic to know, because we want to believe that our doctors are getting it right. And what we're seeing with major problems like cancer, major infections, vascular problems like heart attack or stroke is that about 10% of patients are being misdiagnosed each year. And unfortunately, most people during the course of their lifespan, they're going to have at least one diagnostic error during their lifetime. And if it happens during that inopportune time of a very serious illness, obviously that can be very devastating. So we're always constantly asking ourselves when we hear a significant diagnosis or a major diagnosis in a family member is, where do I get the best care? Who is the best doctor? We don't ask ourselves questions about what is the closest care or what is the least expensive care. We want to get the best care for ourselves and our family members. And that's where second opinions really can be a very valuable tool for patients, family members, your employees, or your members. Next slide, please. Misdiagnoses happen for a variety of reasons. There are only a limited number of ways that the human body can respond to disease states. Depending upon where you're reading, somewhere between 10 and 15,000 different diseases or conditions actually exist. And there are only about 200 to 300 different types of symptoms that people can manifest. So consequently, at the first encounter of in the healthcare system with a patient with a variety of complaints could potentially lead to an incorrect diagnosis because not enough time has passed or not enough of the symptoms have manifested themselves to really point the physician in the correct direction for the proper diagnosis. In addition, we all know that physicians are extremely compressed in the amount of time that they're allowed to spend with patients before they need to move on to the next patient. The average physician is spending about 5 minutes with each patient in the outpatient clinic for actually addressing the reason for their visit. In addition, things are compounded by the fact that many doctors just simply don't know what they don't know. As I remember back during my training, one of my radiology mentors said to me, you know, Peter, you can only see on an x-ray what it is that you know. For those of you who are familiar with the work of Malcolm Gladwell and his popular book Outliers, he felt that a person needed to do something for about 10,000 hours before they could really become proficient and expert on a particular thing. And this is very true in medicine as well. If you're not working in an academic medical center where you see a tremendous amount of patients and referral for rare diagnoses or complex conditions, you can't possibly become good at diagnosing and or managing those patients according to the latest guidelines, innovative therapy, or clinical experimental therapy. Next slide, please. What compounds this as well is that doctors are only human. They make mistakes just like all other humans do. And the sources of these mistakes can come from a variety of different areas. Well, one of these things can be a concept known as anchoring bias of a presumptive diagnosis. So the very first time a physician or provider may encounter a patient, he or she may become fixated on the diagnosis. And despite additional information that comes forward in the future, they may go back to that initial diagnosis simply because it's familiar to them and ingrained in the thought process, and not really entertain any additional options as a possible diagnosis for that patient. They may also suffer from premature closure, where despite additional information that comes forward, or over time a change in symptoms may happen, they may not go back to the initial thoughts and begin to reprocess or take a fresh look at what's going on with the patient to perhaps reconsider additional diagnostic possibilities. Physicians are also overwhelmed with the enormous amount of data that they're presented with, and humans naturally use a system of complex heuristics to try to process through this large amount of data to create mental shortcuts to be able to create efficiencies and arrive at the correct diagnosis and or treatment path. And they may unconsciously misapply one or more of these different heuristic algorithmic thought processes. In addition, physicians, based on benign ignorance, may place more or less salience on certain findings. They may key in on one particular aspect of the patient's complaint or symptomatology, ignore other areas. And all of these things can lead to misdiagnosis. And of course, if the diagnosis is wrong, the treatment can't properly be correct. I see this type of problem occasionally in my own clinical practice as a neurosurgeon, where a patient with migraines, they may frequently go to the emergency room and complain of headache. Unfortunately, if the ER physician incorrectly concludes that this patient with a history of migraines is suffering another migraine, they may absolutely miss a brain hemorrhage, which could have absolutely life-threatening consequences for that patient by going back to what they believe may be happening and failure to entertain other diagnostic possibilities. Next slide, please. Of course, these errors can occur all across the care continuum in many different types of dimensions. If the patient provider encounter, the patient may fail to provide key information on symptomatology or what's actually happening with them. The physician or provider may fail to ask key questions to further elucidate history and or symptoms that patients may be experiencing. There may be oversight in ordering diagnostic tests. There may be errors in interpreting those diagnostic tests. The reporting of those results of those tests may not make their way back to the physician, or he or she may ignore them or not put enough reliance on the results and or follow up with the patient on what these diagnostic testings are. Once a diagnosis is made and a treatment plan has been recommended to the patient, frequently there can be a failure of adherence. There may be unacceptable side effects to the medications that have been ordered. The patient may fail to fill their prescriptions. They may not take it as prescribed, or a variety of other things may happen in terms of how the patient assimilates the recommendations of the healthcare system into their daily lifestyle. In addition, patients may be referred for additional healthcare consultation, perhaps over to a surgeon or a radiologist for further procedures. And there may be key information that's not relayed to that specialist to further investigate the patient's complaints properly, and or may fail to recommend the appropriate treatment because key information has been omitted. For all of these reasons that I've talked about, it's fairly key in my mind as a physician that if you're facing a complex health condition, that you absolutely owe it to yourself and or your family members to get a second opinion on what's going on, to take a fresh look at the information that's out there, to make sure that the diagnosis has been honed correctly, and that the appropriate treatment is being delivered. After all, incorrect treatment is the most costly treatment that can possibly be delivered. To further expand on the financial implications of misdiagnosis and treatment errors, let me turn it over to Frank McGillen for him to explore that a little further.
Thank you, Dr. Rasmussen. Clearly, as Peter shared, the human toll is undeniable for misdiagnosis, but the financial impact is equally staggering. If you look at the avoidable cost of misdiagnosis per 100,000 members, it totals $65 million. You can think for a large employer population or a health plan, it can add up pretty quickly. And in our experience, and we've seen this data from other sources as well, about 28% of patients who come in for a second opinion actually see a change in the underlying diagnosis. And you can imagine, both the personal impact of mistreatment, but also the cost of a treatment that's not really tackling the core issue. Importantly, though, 72% of the time, there's an improvement in the treatment plan. There's a modification in the treatment plan. And that could be because of a procedure that may not be done at a specific facility, a modality that may not be done. But I think one of the benefits that a second opinion from Cleveland Clinic brings is the staff model for staff model of practicing medicine. So there's no financial incentive for a Cleveland Clinic physician to prescribe one treatment path versus another. So culturally, they're just really focused on best outcomes, lowest cost. And we find that in areas like prostate cancer, for example, where there's multiple modalities of radiation plus medical and plus surgical approaches, often there's an approach that's better for the patient as well as can save costs for the employer health plan. And these are just a couple examples of how the financials can be approved through a really professional second opinion program. Next slide, please. As Peter mentioned, that the second opinions are an effective means of combating misdiagnosis. Peter talked about some of the issues, but when you approach a second opinion, and the physicians at Cleveland Clinic are really taking a blank sheet approach, no assumptions. Peter talked about biases. He also talked about heuristics or mental shortcuts that physicians take when there's familiarity with that patient. In the case of second opinion, really it's a full data set and a fresh look at that patient's case. So it really starts uncovering potentially patterns that aren't apparent if you're just looking at the most recent piece of data. There really is sort of a detective mindset, that there's more going on here, that there's probably something being missed. And I think that, it spurs the intellectual curiosity, but it also gets into the experience, having treated many patients in the specific modality or specific diagnostic areas. It's an all-encompassing, thorough review of all information, and I think that really makes a difference in a second opinion. It's not just looking at the latest chart data, but it's gathering all the radiology images. It's getting the pathology, and ultimately we try to get the actual tissue samples and not just the digital pathology readings. And we apply a subspecialist approach to both pathology and radiology. So the person looking at an image for a patient dealing with breast cancer or the biopsy is someone who is super specialized in breast cancer. They're not a generalist, so they can pick out potential slight variations in the data set that really can make the difference between either overtreating or undertreating a cancer, neither of which are a good thing to do. There's finally the opportunity for multidisciplinary review for specific conditions. And when you talk about it, complex condition, particularly where there's multiple modalities of treatment, like the example I gave of prostate, bring in that multidisciplinary team, whether it's prostate, brain cancer, can really help yield the best results from the collective thinking. Next slide, please. But the reality is, pulling this all together, it's not easy. First, it really starts with the specialist. Getting a doctor to review and provide a second opinion isn't good enough. It really is that subspecialist with depth of expertise in that specific condition, as well as all the treatment pathways that are available. The second obstacle to pulling this all together is orchestrating medical record collection. Garbage in, garbage out, and without getting the full data set, it's impossible to have a high quality second opinion. We've really put a lot of energy into both digital technologies to transfer imaging, for example, as well as developing partnerships with health systems across the country and actually around the globe to make sure that we can rapidly get that patient information, put it into our electronic health record system so that it makes it easy for that expert physician to review. Patient satisfaction is so important. I think it's important to put yourself in the employee or the member's headspace where they've just gotten this diagnosis that could be life-threatening or certainly life-altering, and really making sure you meet them where they are and deliver a service that really delights that patient and helps them go from really concerned to that feeling comfortable that they're moving in the right direction. And that comfort and that confidence is so important. And then finally is that speed of providing insight. If you think about it, when you're facing a monumental decision, minutes feel like days, days feel like weeks. We're proud of the fact that we have industry-leading turnaround time, and that's from the initial contact with a patient or the member through the completion and delivery of that second opinion, doing that in less than 12 days. And the bulk of that's actually record collection. If you look at it, once records are complete, we're often turning that expert review around in less than 24 hours, because we just know how important that speed is to that patient. Next slide, please. But reality is that, it's complex, and most health plans and employers just aren't simply equipped to do a second opinion program or process on their own. And it really gets back to scale and expertise. It's a matter of having enough volume that in order to be able to support multiple subspecialties. It's about having the required infrastructure to make sure that from a process standpoint, it's a consistent process, both from the patient experience, but also from the quality of the second opinion rendered. And it's really about prioritization, lack of people, processes, and time. It's not something you can do as a hobby. It's not something that can be done as a side job. And one of the things that is the Clinic by Cleveland Clinic, we've been able to leverage the technology base coming from Amwell, leader in telehealth technology, #1 JD Powers satisfaction in telehealth technology. And we've really been able to leverage that technology infrastructure to make it easier for the 3,500 specialists and subspecialists at Cleveland Clinic to deliver the best second opinion program. And it takes a lot of continuous oversight and continuous quality improvement to deliver that day in, day out at the same level of quality that the patients deserve. Next slide. So there are a few gaps to fill, and we see this day in, day out, and these are some of the things that really make a difference. And the first thing is really about the curation. It's matching the member with that expert based on a review of the case, no matter their location. Our process takes into consideration or leverages a nurse care manager who helps manage that patient's case from the initial video contact through the actual delivery of a second opinion from the specialist. Part of what we do is by getting better understanding of the questions the member has, the question that employee has, understanding what records are available, where the treatment was, medical history, et cetera. We're able to best match that patient with really that subspecialist who has the expertise to help them. There's behind the scenes work ahead of the appointment to make sure that the physician is adequately armed with the right information, and that we're making it very easy in terms of scheduling that video appointment, et cetera. So it's really effective use of both of the individual's time. We really pride ourselves on a seamless, highly coordinated care experience. For most people, hopefully they never have a diagnosis of cancer, but if they do, this is something new to them. They don't know where to go. They don't know how to pull it all together. We help pull it together. And then I think finally, it's all about having physicians who are skilled in website manner, and really who are top of their game, not only in a physical one-on-one interaction, but also can bring that to a virtual world so that we can make sure we're bridging time and space to deliver that best expertise to a person, regardless of whether in a large city that may have access to academic medical centers, or in a remote rural location in the US or around the world. Next slide. So with that, I'm going to turn it back to Gochi, who's going to wrap up and open for questions.
Great. Thank you so much, Peter and Frank, for the presentation. For our audience here, before we jump into the questions, I want to share a quick 2 slides for about 60 seconds to talk a little bit about the clinic, who we are, and how we can help for this topic of discussion today. As some of you might already know, we are the clinic, a joint venture between the Cleveland Clinic and Amwell, bringing together the world-class medical expertise of the Cleveland Clinic with the industry-leading telehealth platform by Amwell. For our discussion today, and everything that you have heard about how virtual second opinions can help health plans and employers and other organizations in improving patient outcomes and also reducing their costs. The 3 things we would like to emphasize as areas where we can help is with the virtual second opinions by Cleveland Clinic, we're able to help provide access to Cleveland Clinic's deep expertise, 3,500 specialists, and over 550 subspecialties. We can do that in a fast and seamless manner to help the health plan member, the employee, the patient reach a fast and seamless peace of mind status by having confidence in their next step and how best to move forward for their specific condition. We can allow all of this to happen with no interruption to their continuity of care. The important, that becomes important as we do provide virtual fast, truly fast, cut the line access to Cleveland Clinic expert physicians and be able to move the employee, the member, the patient to their next step as efficiently and as quickly as possible, allowing them to get access to their next step in their care continuity. So just wanted to run through that very quickly. Again, thank you so much. Now I'd love to, before moving to the questions, I'm going to put up a quick poll once more, give you guys a few seconds to respond, and then we'll move on to the questions. This time would like to just very briefly, I'll give you a few seconds to hear from you. If you'd like to hear more from us about virtual second opinions, please just let us know for a few seconds, and then we'll move into the questions. All right. Just a couple more seconds. Thank you for those who have voted. All right. Okay. Thank you, everybody. That was very helpful. Now we can move on to the questions. Let me check. If any of you have any questions, please let us know. You can type that in the chat box. And a couple of our participants had sent in questions earlier. We can move on with them if not. I'll give you all a couple more seconds. All right, so it looks like we may have answered a lot of the questions. That's Peter, Frank, great presentation and great informative conversation here. There were two questions that were raised to us prior to this via the email that we sent out for registrations. The first question that was asked was, how can this increase access to better care for subspecialties or complex conditions? Sounds like, Peter, you might be able to answer this one.
Yeah, thanks, Kochi. You know, we're very fortunate that we have access to over 3,500 of Cleveland Clinic's subspecialists. As you probably know, there are more than 6,000, 7,000 providers, and greater than 50% of them are really subspecialty practicing physicians. And our goal with the program, as Frank mentioned, is to make sure we get the correct medical records for the patient and their concerns. And then we try to get those records in front of the best possible Cleveland Clinic expert. As someone might imagine, it potentially could be easy for a department chairman or for us to put these requests for second opinions in front of the least busy physicians. That's exactly not how we operate the program. Our goal is to really provide access to the best of the best at Cleveland Clinic. And frequently that's the department chairman themselves or institute leaders, you know, frequently some of the best physicians of the world that we can grant access. To give a understanding of what this kind of subspecialty care can look like, if you have a question around cardiac surgery, we wouldn't just send your question to or your request to a cardiac surgeon. We would send that to that cardiac surgeon who's a specific expert in your area. So we have physicians who only do things like aortic valve surgery or mitral valve surgery. So if your question was about, you know, can I have mitral valve repair or do I need mitral valve repair or replacement, we would get that to one of the senior mitral valve surgeons at the Cleveland Clinic. I'm really not aware of any other second opinion program where you can access this kind of level of expertise from a branded fashion. You know you will be getting a Cleveland Clinic physician and one of the most senior, most expert physicians in the world for your particular concern.
Fantastic. Thank you, Peter. I actually have a few more questions here. I will start with this one. The question is, from a platform perspective, do we simply add the clinic as a service on our white label Amwell solution? Then working with the patient, are they given a service key to get access? Frank, you may be able to take this one.
Yeah, it'd help if I unmute. Yeah, great question. And I think that's, one of the beauties of, running our whole process and our whole service on Amwell Technology is it makes it really plug and play for employers or health plans who are using the Amwell platform. We can rapidly integrate. It becomes a single sign-on for that user. So we try to simplify the process because, again, people have too many apps, too many logins, et cetera. How do we make it easy for that person to get access to the best care? I'll also say that, for employers or health plans who are not Amwell customers, we make it really easy for them as well. So, our goal is to really make the integrations simple, to make the access simple, because we know that's an important ingredient to the success of any program.
Great. Okay, thank you. Another question, an international question this time. We have a hello from Panama. Our participant asks, they've had a couple of patients interested, but they need the answer in 1 or maximum 2 days. So they're wondering, how long does it actually take from when you receive the medical documents to patient receiving the feedback? Peter, would you like to take this one?
Yeah, so on average, from the start of our process to the completion of the opinion is 11 days. The vast majority of that time of the process is consumed with medical record acquisition for us. Actually, 9 days of time of that 11 is medical records. So if there's a request coming from, say, Panama, and the medical record data set is complete, once we receive that, as Frank mentioned, frequently we can turn that second opinion around within 1 to 2 hours, or excuse me, 1 to 2 days. It depends on obviously the nature of the request, the completeness of the medical records that are coming through, and the availability of our experts. But 1 to 2 days turnaround time once we have the records is not unusual.
And I just want to build on Peter's comment. I mean, the fact that we're an integrated program, it really is easy for us to quickly connect with the best physician, the right physician. And in the case where it's, where there's an urgent need for that second opinion based on the patient's condition or the member of the employee's condition, I don't think anyone's able to turn it around as quickly as we are, because again, we're really controlling that process from end to end.
Okay, great. Thank you both. We have another question about the cost of, or the overall cost savings, the $65 million. So our participant is wondering, does the $65 million avoidable cost represent actual cost savings by getting a second opinion from the clinic? In other words, does it factor in the cost of the correct treatment from the clinic, or does it just represent money wasted on the wrong treatment?
Yeah, so that $65 million was reflecting the overall cost of, excuse me, misdiagnosis and mistreatment. We've done our own research working with a third-party analytics firm where they analyzed a large data set of our cases. We found on average there's a $12,000 savings for the typical, within the typical change in diagnosis or change in therapeutic pathway based on patients going through our program. And that was looking at, initial diagnosis, subsequent diagnosis, and treatment path, and looking at specific costs based on published cost data. And it ranged, even higher than that for certain conditions like musculoskeletal. So we've got good data, and we'd love to sit down and have a follow-up conversation, and we could review in a more intimate format and go into a little more detail on the economics.
Yeah, I think it's important to know here, Frank, too, that there are going to be some patients where Cleveland Clinic doctors agree with diagnosis and treatment of the local physician. In that situation, what we universally hear back from the patient is the tremendous sense of relief that they have knowing that their local doctors have things right, and that they can move forward in confidence with their local care team.
Absolutely.
Great. We have a couple more questions. This one is about following a virtual second opinion, what percentage of cases are then treated by the Cleveland Clinic? Peter, yeah.
Yeah, it's obviously variable and depends upon the nature of the request that comes in. What we're finding across the board is that about a third of the patients eventually transition their care to Cleveland Clinic for in-person care. Obviously, this happens a little bit more frequently in the cardiac world, where patients place great stock in the reputation of Cleveland Clinic and cardiologists and the cardiac surgeons. And if they find out that their particular problem is amenable to treatment at Cleveland Clinic, that they will frequently elect to transition their care there. In other areas like neurologic disease or gastroenterology, et cetera, that conversion in-person rate's a little bit lower because frequently the same level of service can be acquired locally and or with modifications based on our recommendations.
I just want to build on that is, the conversion to inpatient care or in-person care at Cleveland Clinic, it gets skewed very heavily by direct to consumer. Because we do have, do offer the service and market to patients who may not have availability through their health plan or through their employer. But it's important to note, and then, we work with national health plans, we work with international health plans and employers, that not all roads lead to Cleveland Clinic. In some cases, that is, Cleveland Clinic, this is in case of some cardiac conditions, it is the best endpoint. But oftentimes, as Peter said, there's great local care, and part of what we help do is help that patient find, if their current physician isn't the right one, based on the physician's network and database, we're able to connect them with a specialist in their local area who may have that expertise.
As Frank mentioned, Cleveland Clinic physicians are on salary. There is no financial incentive to drive patients to in-person care in Cleveland. Obviously, we're willing to help patients if they so choose, and if it's right for their benefit structure. But the goal is to really get patients the best diagnosis, best treatment recommendations, and leave it up to them and their employer or payer to ascertain what location of delivery is best for them.
Okay, I'm looking down this list. We have a couple more added questions, gentlemen. One of them is about, hang on, is there an option to consult on entire populations such as ISNP? I'm not sure what that one is myself, if Peter or Frank, if you're familiar, ISNP.
Living in several different worlds, I can't, I don't know what that abbreviation stands for.
John, if you're still with us, I cannot see just at this moment, but if you'd like to re-ask. Institutional special needs programs is what John says. Is there an option to consult on entire populations such as institutional special needs programs like managed care and Medicare?
I think that would probably be a discussion that would be more appropriate with Cleveland Clinic proper, and we know we'd be happy to help develop those contacts for you.
Yeah, and just to echo, I think, that there's specific questions that are like that. Let us have your contact information. We can have an initial call and make sure if we're not the right people to connect with, we will. I think the one thing I did want to emphasize is that we are working with highly specialized populations. So for example, with one large national, or actually one large global employer, we're doing a specialized program, inclusive care program for the LGBTQ plus community. And we really, if you think about that, it's a very specialized type of care. But with Cleveland Clinic's depth, we're able to provide the experts for a very specific area and that we're asking delicate questions. We're also doing specialized programs in cardiology and specialized programs for different partners in oncology as well. So I think if there's specific populations, we're open to brainstorm, and if we're not the right folks, we probably know the right people to connect you with.
Okay, thank you for that. This might be, actually, let me get to that after. This question is also an international one. I have just started to offer a second medical opinion among my referrals. I am the country rep for Guatemala and El Salvador, but have had the experience that the patient prefers to physically attend the appointment. After you review the documents in a second medical opinion, have had the experience of patients having to attend an appointment in person. Have the patients had the experience of having to attend an appointment in person is their question.
Well, I think it's, the goal of the program is to try to provide access to patients around the globe to Cleveland Clinic expertise. Frequently, recommendations can be made at a distance that can be implemented locally. Of course, if it's the right thing for the patient to be seen in person, or based on the recommendations that are made as part of the second opinion, the patient would like to be seen in person and or have their care delivered in person, we help facilitate those in-person appointments for a smooth transition wherever the patient may happen to be in the world.
And also say for international, particularly where there's potentially a language barrier and or some different regulatory, there are cases where the Cleveland Clinic physician is working with a local physician to provide that second opinion to the patient. So we try to, we make sure that we're trying to match the needs on the international market based both on the regulatory as well as the patient needs. And ultimately, it's all about unlocking access to the best experts, and technology we think is the way to do that.
Great. I'm going to ask another question that was raised to us via email prior to the webinar. Frank, you may be the one to answer this question. How is the virtual second opinions by Cleveland Clinic different from other solutions out there?
Yeah. I highlighted earlier, I mean, we're unique in the fact that we have a fully integrated program that's run that takes, I'll call it, the best in academic medicine and the best in a commercial program. So, we have both the Amwell DNA, which is all about make it easy for the patient, make it easy for the patient member or employee. Think about it from our client standpoint in terms of reporting, in terms of simplifying the processes for our clients. So we're able to really kind of marry again that patient experience, that client experience, and match it with the best care in the world. We're not hunting for a specific physician or specialist like most commercial second opinion programs are, because we have access to the Cleveland Clinic staff. And we've experienced with them. So I think the fact that that we really have a patient-centric, a people-centric program, access to the best technology, access to the best physicians in the world really helps us deliver something that's unique. Our net promoter, we have world-class net promoter, patient satisfaction in the 90%, not 90% range, and we see in terms of intent to follow through with the recommendations very high. So we're proud of what we built, and I think the patient experience speaks for itself.
I think the other thing to mention too, Frank, is that we do have the ability to offer some flexible business models to meet specific circumstances.
Absolutely.
Okay.
One additional point here, Frank, which I think is very in the forefront of our mind, but may not be obvious to the attendees here, is that in contrast to many of the second opinion programs that end with just a written report, for U.S. based members and patients, our program almost always ends in a video visit between the Cleveland Clinic expert and the patient. They're given the option of video, telephone, or written report only. Of course, if they do choose telephone and video, we do follow up with a written summary of that conversation as well.
Yeah, excellent point. Thanks, Peter.
Okay, at this point, I'd like to turn to our audience once more to see if there are any additional questions. There were a couple questions that seemed specific that we'll be happy to follow up individually on. But if there are any other questions, I'll give it another few seconds here.
So Gochi, if people are interested, where should they go to reach out to us for more information?
Yes, that's coming up next. So let me close my questions screen here. So everybody, again, I'll take this opportunity to just get us to the closing of this webinar. Thank you so much for joining us. Like I said, if we didn't get to some of your questions, there were a couple that seemed specific, so we'll get back to you individually on those. If you didn't get a chance to ask any questions, or if you have any other questions later, or if you'd like to connect with us, those of you who already shared that you'd like to hear from us, we'll get back to you very quickly on that. And if you would like to do that at another time later, of course, visit our website, theclinic.io, and share with us what that you'd like to connect with us, and we'll be back with you as quickly as possible. You will have a post-webinar survey, which will open as you exit the event as well, and you will receive a follow-up email with our slides and recording from today. So there are multiple ways to touch base with us after this event if you would like, and we'd be happy to talk to you soon. Again, I'd like to thank our presenters today for a great presentation. Thank our audience for great questions raised. And I'll look forward to seeing you all in other events that we'll be having in the near future as well. And with that, I'd like to take the opportunity to say thank you and have a great day, everybody.
Thank you.